welcome to Long COVID Foundation podcast. My name is Dr. Valentina Viduta, and I'm a Long COVID Foundation trustee. This channel is for long COVID sufferers, researchers, practitioners, and a whole host of other people who wants to learn more on COVID. The Long COVID Foundation aims to find the best rehabilitation solutions for long COVID sufferers. We provide the knowledge that you can use to understand your symptoms better. So please subscribe to our YouTube channel and like our videos. Today we have invited Dr. Gabriel DeMarco, who is a rheumatologist consultant at the Leeds Teaching Hospitals. As usually, we're gonna start with an overview and some knowledge on rheumatology issues, on diagnostics, tests, and at the end of the podcast, we're gonna have 3 of your questions. So please stay tuned, we start. Thank you very much for joining us today. We really need your expertise on rheumatology and in light with long COVID. So I advocate the group on long COVID, and we have quite many sufferers who started to feel inflammation in joints, in elbows, in feet, and hands. More often I see that people are questioning, why does this happen? So from your expertise, from your research background, what do you see currently is happening? Could you give us an overview what is arthritis in light with long COVID?
It is a subject that is expanding at the moment. Most of the knowledge we are trying to use as the background to then develop scientific discussion about what is related to COVID, and specifically in the area of rheumatology, comes from what we know scientifically about the interaction between human body in general and viruses, which are not exactly microorganisms. They are not live. The first stage of exploration of this data has been about what is the way COVID strikes people who have a rheumatic disease and are at the same time on treatment for their rheumatic disease, because there is a specific interest in that. And then the huge and consecutive series of lockdowns across different nations, and then the vaccination campaign has also started. So all of these 3 societal interaction do matter a lot, because part of the COVID-19 spectrum is about the serious respiratory illness, which is partly driven by an inflammation overreaction, which is generated by immune mechanisms. So it is hypothesized, for example, that people who are taking rheumatic medication, or to be more specific, some form of rheumatic medications, might be protected by the most severe forms of COVID-19. And in fact, that could be a reflection of the discovery that actually desmetazone, which is a steroid and at large an immune suppressant treatment, actually does help people who have respiratory COVID-19 to prevent a more serious course of their disease. So this is one line of scientific discussion. And the other, of course, has been preventing contact, which has in many ways altered and delayed the gathering of data about COVID-19 and its interaction with rheumatic diseases, because when you lock down people, no interaction with viral can happen. And as such, that is done for a prevention purpose, but limiting interaction, you don't have chances to gather more data that you would like to see into. So lockdowns have somehow reduced our way to speak to people, and specifically speak to rheumatic people, and gather more experience. And then there is the massive rollout of the vaccination campaign, which is unprecedented. And I like to stress that whenever you expose general population to a massive program of intervention, whatever it is, but in this case of vaccination, you would expect some intended effects. So the purpose is to protect more vulnerable individuals and achieve what is called the herd protection. But exposing so many people to an agent, a vaccination, which can be seen as a drug because it can have side effects, then of course you do discover, and very easily, even very rare side effects. Just if you think of the sinus thrombosis happening, which is an event that is very significant and could have serious consequences to health of the individual involved, but it in itself, it is very uncommon, it is rare, and it would have been very difficult to pick up if the size of the mass vaccination would have not been the way it is happening. So if we just had the standard flu seasonal vaccination campaign, we would not have been able to pick up this kind of signal. Just to give you the proportion, because the numbers at stake are probably some 6 times different. In the seasonal flu vaccination campaign, many members of the general public are invited to have their job, and we are talking about some million people in the UK. With COVID-19 vaccination, the actual target is basically to vaccinate all the adults and even some members of the public who are not adults as yet. So it is such a disproportionate number, and having such a large exposure, then it is very easy to find that. However, all of this does not address your question about long COVID. We suspect that in form of the interaction with COVID, either serious or mild from the respiratory point of view, and as such, not requiring hospitalization, we do expect that a number of people exposed to the interaction with the COVID-19 will report a number of rheumatic events, and we cannot still define yet what exactly long COVID is. We certainly know, and we do expect that will happen with the COVID-19 as well, that some rheumatic diseases can be triggered by interaction with viruses. The most probable mechanism, this is highly hypothesized. One specific individual builds on step-by-step predisposition to have to develop a rheumatic condition, and usually the viral infection or another kind of trigger is the very last trigger that unleashes the disease in full. So we do expect to see something like that, which is not exactly what I understand is now long COVID anyway. Long COVID as a part that is of rheumatologic interest in its development of musculoskeletal symptoms that for now is studied in a restricted tertiary centers area. I must say that I was, this is in quotation marks, lucky not to see myself among the patient I am taking care of long COVID in itself. But, it's just a restricted view, restricted to my specific practice. My research patients have been asked to comply with the guidances of lockdown, so they have not exposed themselves to COVID, and they have been vaccinated. I do remember specifically one case of a mild COVID-19 infection among those patients, which resolved favorably. There was no need to go to the hospital. It was treated at home and taking a pause of a couple of anti-rheumatic medication. So far, they have not developed a long COVID as a consequence. What is happening with long COVID in general is better focused in long COVID clinics. There is one here in Leeds operating. And so far as rheumatologists, we are also operating in a restricted way by telephone consultation. So our activity as clinical rheumatologists is restricted in many ways because of the current rules of the existing rule of the lockdown. So we can't interact so much with our people so far. One of my patients has complained about symptoms that could be due to COVID. They had a COVID infection, and it might be. So this is just to show you that unfortunately this kind of interaction requires much more time to have a better idea of what's going on, unfortunately. We tend to see, this is from the rheumatology perspective, more or less two kind of occurrences. One, a rheumatic condition triggered by the COVID disease, or some presence of musculoskeletal symptoms such as pain, which seems to be a part of long COVID. We still don't know if that long COVID is how long that it is, because in parallel with other viral diseases, we do know that after a contact with the viral illness, it might well be that people can develop musculoskeletal discomfort for a very long while. We do not call usually that a dangerous situation, because other than the pain, luckily it doesn't generate permanent damage into the bones and joints. Still, it is very unpleasant, and there are reports where long post-viral illness could last even for a couple of years. I have so far no idea if that will be exactly replicated by COVID itself. If that will be shorter, if that will be longer, we still don't know, unfortunately. But so far, it is safe to say that we are seeing a pattern that basically is replicating the experience so far gathered with other viral illnesses.
People are willing to understand whether COVID can be a reason for their arthritis to appear, because prior contracting COVID, they didn't have any issues related to rheumatology. And after COVID, and then 3 months and 6 months post COVID, they started to experience this rheumatology issue.
I see.
And we are mainly concerned how we can help people is to give some knowledge what they can do when they see their GPs. What are, for example, basic tests that can be done at the GP level?
It is, in a sense, good that all this attention is giving momentum to a couple of scientific questions that might finally have an answer. So basically, we think that we should be developing more advanced tests that are currently not available. And this could be an invaluable chance. That has also brought under the spotlight what was earlier a niche kind of problem. So the same kind of instances that you are talking about were already there with other viral diseases. They were just under the radar because they were reported in an environment that was not focused so much on a viral illness. So there is a good attention, and I hope that something positive will come out from that. From the basic level, it would be very important to try to make a distinction between what is a symptom of pain that affects one individual, and it could be even a severe form of pain, but does not develop into damage of potential destruction of bones or joints. Form of rheumatic symptom that is actually the very first sign of a potentially destructive disease. So when somebody have musculoskeletal complaints and need to have a checkup, shall we say, one important thing to try to be aware of is if they see their joints altered in shape and swollen. If you have a look at the knuckles of your hand, and if you see them to become apparently swollen, and it is fairly easy to make a comparison between, say, one end and the other, you might spot that one knuckle compared to the one of the other side is simply bigger. It is apparently bigger. So that's a sign that that individual should seek medical attention as soon as possible at their GP, whom usually will refer them straightforward to a rheumatologist, because arthritis is the area of expertise of rheumatologists. So usually the GP will assess the patient, hopefully in person or maybe through a form of video conferencing, where the patient can show their hands through a video platform to their GP. The GP will recognize there is a problem, will suggest a couple of basic tests which belong to the kind of tests aimed at spotting gross inflammation in the bloodstream, and will probably refer straightforward to the rheumatologists. This kind of arthritis, which seems to be dangerous, is also one that develops in close temporal relationship with the infection, and has no other apparent causes behind it. So, for example, I would say a physical trauma, somebody hammers one of the finger, and of course the finger becomes swollen. Okay, it also is an example of how easy it is to rule out obvious mechanical triggers. So if somebody wakes up with arthritis that was not there the day before, there is apparently no possible trigger unless they hammer themselves while sleeping in the bed. Quite unlikely, isn't it? So if that happens, it could be serious and requires investigation. Luckily, still in this instance, many forms have a resolution, although it requires usually months, may still not generate permanent kind of damage, which is a very positive thing. I must say that frustratingly, most of the forms affect individuals with pain, which could be even excruciating pain, still without swelling, so real opportunity to make the quality of life really bad, and could be affecting the individual for months and months. We suspect because the body needs its own time to wash out everything from the COVID-19, but that is more theory than anything. And even more frustratingly, unfortunately, there is no test at the moment that can tell us how long this pain symptoms without articular swelling will last in a specific individual. Such a test does not exist. And that's why I welcomed the opportunity, because if we can study better and provide more reassurance to the public and tell them we know what's happening, even if it is a discomforting experience that can affect and impact your life a lot, ultimately you don't have to fear for negative outcomes concerning to your health, and maybe we can help managing the pain. That could still be a good way to offer some help, but this is all in development. I feel it is early days in this conversation and more will come out. However, if we could offer an advice about red flags, I would say to anyone, if they notice they have a swelling in their joints, which is unexplained, related temporarily or not with the COVID-19 infection, they should seek advice from their doctors, and probably their own family doctors or GP. They will send them straight forward to the rheumatology department for an assessment.
We also see quite often, maybe you can comment on it, so why these long-lasting symptoms and autoimmune diseases are more common in women?
Looking across the spectrum of the many rheumatic diseases that exist, a few exceptions see male gender predominance. It's just a handful. Sorry for the difficulties of the name, but ankylosing spondylitis and gout are mostly male diseases for male, traditionally have been. Some perspective is changing though at the moment, and some lifestyle and increased diagnostic means are even changing that. But traditionally, rheumatic diseases have been a field where we do traditionally assess more women than men. It does not come as a surprise, probably is a bad term, but it is very, very in keeping with the traditional knowledge that we have about rheumatic conditions. So rheumatic field is female. I have personally assessed thousands of patients in my career so far, and the striking majority have been female. Yes, that is what we see in rheumatology, actually.
But is it somehow hormone related?
We suspect there is an influence as a factor that conditions somehow many of the rheumatic diseases. Systemic lupus erythematosus, for example, the influence of hormones is so strong. For other diseases is less apparent. Certainly the hormones do have a role, which is mitigated or enhanced depending on the specific rheumatic condition of interest, but it is a factor. And unfortunately, one that cannot be quantified at the moment. So we do not know how much we should expect worse with the specific hormone pattern, for example, because we do know that everyone is different. So across the genders, the human body uses many common hormones for males and females, and within the same gender, with a huge variability related to many factors of genetic makeup, amount of hormones, and so on and so forth. We do not even know how to quantify that at the moment, but definitely there is an influence, and for some diseases it is so strong.
3 questions from our group members, which are very specific to their case, and I hope you could give us a little bit of information on that. So one question I have is, we already discussed vaccines, and is there a chance that a vaccine, I'm not naming any of those, just a general vaccine, can cause reactive arthritis in long COVID patients?
The vaccination, yes. We suspect it has potential for reactive arthritis, and there are reports showing that, or a variant of reactive arthritis, which is nomenclature here is disputed, but it is considered arthritis arising in very close temporal relationship to a vaccination, and to some that is not exactly reactive arthritis. However, the name doesn't matter much. The temporal relationship, it probably is the common denominator, the umbrella that encompass this kind of problems. And we do expect, and we have seen that happening. It is not exactly occurrence that would pertain to long COVID itself, because by definition, reaction of arthritis around the time of the vaccination may occur in people who have been infected or not, first thing, and secondly, is very close in its temporal relationship to the vaccination event or to the infection event. When I say very close, I mean within 4-6 weeks from the event. While when we talk about long COVID, we clearly are talking about something that develops much more along the lines of months. So in that respect, if arthritis arises in long COVID, I would more suspect another form of arthritis than reactive arthritis. That said, which is, just a distinction that rheumatologists make, still it is an occurrence, either being reactive arthritis or another form of developing, more down the line, still would be an event that clearly would require the attention and evaluation of a specialist in rheumatology. Luckily, this kind of events are self-resolution, and I can give you as a rule of thumb reference, in 80%, 80, of the cases, there is a full and even spontaneous kind of resolution. So people need advice about how to manage the pain and swelling, the arthritis, but the event luckily ends without leaving complications that are dangerous for personal autonomy and ability of moving their body, which is the core of the arthritis damage, of course. So that tends not to happen in the majority of cases. So I hope I can bring some good news here. Assessment is still needed, but it is to give the perspective of chances. Chances are more in favor of a benign course of the disease rather than having a problem that becomes chronic and ends up with disability.
Another one is very specific. So if infection markers, the CRP, is always above the norm, and the ACCP levels above 500. So this person can, when sees rheumatologist on a regular basis and knowing the history of an illness, and with regards to long COVID, because it is developed through months of long COVID, can this person be given tocilizumab as a potential treatment?
You touch an area that is highly regulated. So tocilizumab has been trialed in COVID-19 serious infection for the purposes of treating a life-threatening event that normally occurs in intensive care. And that is a specific setting of investigation. Otherwise, tocilizumab is a regularly licensed drug on the market for the treatment of rheumatoid arthritis. It is a drug that belongs to a class of anti-rheumatic drugs, colloquially called as biologics. Person who has specifically a diagnosis of a rheumatic condition called rheumatoid arthritis can have tocilizumab, but the use of tocilizumab is very regulated. So it is allowed for physicians to prescribe tocilizumab for people who have rheumatoid arthritis, provided that they have failed other forms of treatment. That is the regulation as it stands so far. So we are talking about a drug that is second tier in the pyramid of treatment of rheumatoid arthritis. Tocilizumab is also licensed in other niche conditions, which are not arthritis anyway. So going back to the situation, we are talking about an overlap of instances. So people who have the CCP antibodies and who have permanently altered C-reactive protein are those ones who are at risk of developing rheumatoid arthritis. Rheumatoid arthritis that becomes apparent again with swelling of their joints, mainly the little joints of their fingers, and they become apparently swollen. I don't need to tell you how the picture is, because actually it's even in the public domain. The rheumatoid hand is, very, very typical. So all those features become apparent. There might be an overlap between long COVID and rheumatoid arthritis. It might well be that simply the COVID event is just the last step of that specific individual, finally developing their rheumatoid arthritis, which might have come later, triggered by something else, but still happening. That is impossible to single out, unfortunately. However, if the sum of event is having the CCP positive and the C-reactive protein consistently altered and having in their hands or in their feet articular swelling, that is again an excellent reason for seeking medical advice as soon as possible with the rheumatologist. And here, time is crucial, because if the knuckles are swollen, I advise strongly everyone to see a rheumatologist as soon as possible, because here time is crucial. We are talking about factors of quickly arising damages into the bones, then generating disability. So I would not delay seeing the rheumatologist more than 6 months. And probably that's even, it's very tight timeline. And they should, and they will, 100% of case, advise to start a drug called methotrexate, which is the first step to treat rheumatoid arthritis. Of course, later on down the line, people can have tocilizumab, especially if they do not respond to a first course of methotrexate, or people might not be able to have methotrexate for a number of different reasons, for example. However, good news, there are so many options to treat rheumatoid arthritis that certainly a drug, not necessarily tocilizumab, but a drug that is effective in relieving from that disease, can be found. We have so many means available at the time. So the important thing is that the individual concerned realizes there is a problem and brings that to medical attention as soon as possible. That's the crucial thing. After that, a way to manage it will be found with some drug, tocilizumab or other agents. It will be found. I'm pretty confident of that. But the important thing is not to delay. What you're talking about, I am very grateful for this very specific question, but it is so specific that actually it tells me rheumatoid arthritis everywhere, which probably has been finally triggered by COVID-19. And I am sure it requires rheumatology attention as soon as possible. That's my conclusion.
And the last question, I don't know whether it is rheumatology related, or you can, as a medical doctor, can conclude on reasons why does this happen. So there is a person who complained that his fingers are numb and there is sensitive and purple bluish skin. So all tests came as normal, and they've been sent to rheumatologists. What
could you provide some details? I know it might be silly, but the skin located where in the body?
Right. So we talk about our fingers, legs, and hands, and they feel numb on touch and sensitive as well.
It is, I think, it could be an instance of a described consequence of COVID contact, might generate not an event that is of respiratory concern, but it is of cutaneous skin concern. And it is not a frequent problem, but still well recognized by the dermatology, which is the doctors of the skin community. To be distinguished from what is of rheumatology interest, which is Raynaud's syndrome, which is an instance where fingers can become blue, but before becoming blue, they become utterly pale. So it is a dynamic where the discoloration of the fingers becoming pale is never missed by the patient who report the instance. So I think you are more talking about the specific and events related to the contact with the virus which our friends dermatologists know so well. And I would urge those people to contact their dermatologist as soon as possible.
Okay, thank you very much, Gabriel, for...
My pleasure.
Let me remind you that all our videos are for educational and informational purposes only. For medical advice, please speak to your general practitioners. Thank you for watching and see you next time. Bye!